Hi, I'm Alex, sitting in for Jeff Callis from Kidney Couch. Welcome to Around the Couch. In this episode, the use of a biopsy for a tumor in the kidney is explored in depth. According to the American Cancer Society, for most cancers, a biopsy is needed to confirm the diagnosis. For masses in the kidney, a biopsy is not always needed or recommended. Imaging tests can often provide enough information for a surgeon to decide if surgery is needed. The diagnosis is then confirmed when part or all of the kidney is removed and is looked at in the pathology lab. Based on my research, that's the opinion of the majority in the medical field. A biopsy for most tumors or masses is usually a step in the clinical decision-making process. Not so for all masses in the kidney, as I found out after I was diagnosed with renal cell carcinoma. Use of a biopsy to confirm a kidney cancer diagnosis or to provide additional clinical information that will guide treatment, such as the type and grade of the mass, usually outweighs the minimal risks or complications from the biopsy procedure itself. As with all medical decisions, the patient needs to have a detailed discussion with their physician, get a second opinion if you would like, and have the biopsy procedure performed by an interventional radiologist that is experienced in performing kidney biopsies. You need to consider the risks, complications, and benefits that a kidney biopsy will provide and then make an informed decision. Your decision. Again, imaging alone is often all that is needed to confidently identify and diagnose a cancerous kidney tumor. That is according to the American Cancer Society and several studies conducted by top medical centers. Generally, if a mass that is contained to the kidney is 7 centimeters or greater in size, imaging alone can be relied upon to accurately diagnose a cancerous tumor. CT or MRI are the most common diagnostic tools. PET scans are also used in some cases. Use of a biopsy to diagnose, confirm, or gather more clinical information to guide treatment decisions for kidney masses has historically occurred in about 20% of cases. Situations in which a kidney biopsy might be clinically indicated include 1. When the results of imaging tests are not clear enough to make a diagnosis with high confidence. 2. To confirm a tumor is cancer if a person might not be treated with surgery, such as with small tumors that will be watched and not treated, or when other treatments are being considered, such as ablation or cryotherapy. A kidney biopsy is a procedure in which a sample of the kidney is removed and examined under a microscope. When having a biopsy of a suspected cancerous tumor in the kidney, several samples, usually about 3, are taken in different areas of the mass to improve the quality of the biopsy procedure. The biopsy is usually performed by an interventional radiologist who inserts a thin, hollow needle through the skin below the ribcage directly over the kidney and into the tumor, with the use of ultrasound to help guide the physician in finding the mass in the kidney. Patients are given a local anesthetic to numb the site where the needle is inserted. According to the National Kidney Foundation, as well as top medical centers specializing in kidney cancer treatment, the risks of a kidney biopsy are very small, but not zero. As with any minimally invasive medical procedure, there are risks. When the procedure is performed by experienced physicians, the procedure is considered very safe. There is a lot of debate whether cancer from the kidney mass can be spread by placing a needle in the tumor and retrieving the sample out of the body. Some patients are reluctant to have a biopsy, fearing cancer cells will spread along the needle track, known as seeding. Again, most medical experts agree that when a biopsy is performed by an experienced physician, the risk of seeding is very low. Advancements in technology have also reduced the risk of accidental spreading by using a sheath around the needle to contain the sample when being retrieved. There is also no shortage of opinions in the medical field whether a kidney biopsy should be performed on masses in the kidney that are between 2 to 5 centimeters in size. The radiologist/urologist's confidence level in identifying a cancerous mass in the kidney by imaging alone is less for tumors 5 centimeters or less. A biopsy can improve diagnostic accuracy in some of these cases, with the goal to confirm the diagnosis from imaging, as well as to prevent surgical removal of part or all a patient's kidney when the mass is not cancerous. Only the pathologist's diagnosis post-nephrectomy provides the ultimate answer to this question. Who wants to undergo a removal of part or all your kidney if the mass is not cancerous? Some studies have shown that removing a kidney or part of a kidney that turns out not to be cancer occurs in up to 7% of cases. I would not want to be in the 7%. Who wants to go through that surgery for a tumor that was not cancer? Hard pass on that one. From a personal perspective, I was diagnosed with stage 3, grade 3, clear cell renal cell carcinoma with renal vein invasion in January 2003. The mass was 5 centimeters. I had a biopsy at Mayo Clinic, Rochester prior to having a radical nephrectomy. I was diagnosed with a mass on my right kidney while having a CT scan to confirm that I was passing or had passed a kidney stone. Thank God for that kidney stone. The radiologist and urologist were about 85% confident that the mass was renal cell carcinoma. Given the recommended course of action was surgical removal of part or all the kidney, I decided to have a biopsy to confirm the mass was cancer and learn more about the type and grade of the tumor if it was indeed cancer. In February 2023, I underwent a biopsy of the right kidney 2 days before the scheduled radical nephrectomy. The biopsy confirmed cancer. The radiologist who interpreted the CT scan, the physician who performed the biopsy, and the pathologist who made the diagnosis from the biopsy were confident, 90%, that the mass was a stage 1 to 2 renal cell carcinoma, clear cell, and that it was contained to the right kidney. I made the decision prior to the biopsy that I was going to have the kidney removed regardless of the diagnosis. The mass was 5 centimeters in diameter and growing. The biopsy did confirm I had renal cell carcinoma, clear cell, so I went into surgery knowing that I was doing the right thing, cutting the cancer out. I'm not sure what I would have decided to do had the biopsy results come back negative. That would have been a more difficult decision and one that I would have taken more time to consider. I would have gotten a second opinion for sure. The procedure was called a percutaneous kidney biopsy, using an ultrasound device to help the doctor guide the needle into the kidney to remove tissue samples. The nurse who sat by my side and held my hand during the biopsy procedure itself was outstanding. She told me prior to the procedure that the physician would give me a shot of lidocaine to dull the pain of the biopsy needle itself. It would feel like a prolonged bee sting. She was right. She coached me through it while the resident and consultant pierced my body below the rib cage and wrangled a device down to the kidney under ultrasonic guidance. The 3 loud clicks when the device took samples of the kidney didn't bother me at all. Although I was surprised how loud it was, I thought tissue, muscle, and fat would muffle the sound more than it did. Not the case. It sounded like it was outside of my body. The biopsy confirmed the bad news. Right kidney, positive for malignancy, renal cell carcinoma, clear cell type, ISU grade 1 to 2. Immunohistochemistry revealed that the cells of interest were positive for CA-IX, while negative for KIT and CK7. This is a characteristic immunochemical profile for renal cell carcinoma, clear cell. This brings up a limitation of a CT scan and a kidney biopsy. In my case, based on the CT scan, the radiologist and surgeon were 85 to 90% confident the mass in my kidney was cancer. However, a definitive diagnosis could not be made with 100% accuracy. If a physician ever tells you that, get a second opinion. They may be confident based on their experience and expertise, but they cannot be 100% sure given technology where it is at today. Let's review the thought process and decision-making I went through when deciding whether to have a biopsy prior to the radical nephrectomy as well as the biopsy itself. 1. Factors that influenced my decision. Based on the CT scan of my abdomen and pelvis, the radiologist and urology surgeon were 85 to 90% confident that the mass in my kidney was cancerous. The recommended surgical treatment was to have a radical nephrectomy. I wanted to know with greater certainty that I had a cancerous mass prior to removal of the entire kidney. I also wanted to know what type and grade the mass was prior to surgery. The more information I had, the better. I had a major decision in front of me. 2. How involved did I feel in the decision-making process? Very involved. We discussed the pros and cons of a biopsy. I thought about the information my surgeon shared with me. I went home and researched information from the top 3 cancer centers in the United States. I thought about the pros and cons for one day. I made the decision to have a biopsy. 3. The biopsy procedure itself. The biopsy was straightforward, performed as an outpatient procedure. The entire process from start to finish lasted just over 2 hours. I went home right after the procedure, with my wife Cindy as my driver. It's not recommended that you drive a motor vehicle after the procedure, even though you have only a local anesthetic. 4. What was the level of pain during after the biopsy? The only pain I experienced was when the lidocaine, local anesthetic, was injected into the skin to numb the needle insertion site. I would describe it as a prolonged bee sting that lasted a couple of minutes, just like the nurse said it would. I'm afraid of needles, especially long ones. Luckily, I was lying down already, so the risk of dropping to the floor was 0. The insertion of the biopsy needle itself was slightly discomforting. I could feel the needle moving through my body, but it was not painful. I expected it to be excruciatingly painful. When the biopsy samples were taken, I heard a loud click, which the physician gave me a heads up about before each sample was taken. After each of the 3 samples were taken and I heard the click from the device, the interventional radiologist asked me if I was okay. There was no pain associated with the samples taken. I was surprised the sound of the click was as loud as it was given it was inside my body. The noise didn't bother me at all, and as I said, there was no pain associated with the samples taken. 5. Did I experience anxiety before or during the procedure? Very little. I was more focused on getting additional information from the biopsy results than I was about the procedure or risks. I was a little anxious during the procedure itself, not knowing what to expect. I have a very low pain threshold. The procedure was a breeze to me. I thought the procedure would be more painful than it was. I was pleasantly surprised. 6. Did I experience any post-biopsy symptoms or complications? I did not. I thought I would have lingering pain after having a needle threaded from the side of my body to the kidney. Slight discomfort by the sight of the needle lasted just a few hours. No complications from the procedure either. 7. Did I take any time off from work or daily activities? I was retired, so work was not an issue. I took it easy for a day and a half. I had a radical nephrectomy 2 days after the biopsy. That was much worse. 8. What was my satisfaction and overall perception of the biopsy? I was very satisfied. My overall perception of the biopsy is that it was a straightforward procedure with minimal risk and high reward. The samples provided me and my surgeon with confirming information that the tumor was cancer and provided new information regarding the type and grade of the cancer. The biopsy did not have a negative effect on my quality of life at all, before, during, or after the biopsy. I would do it all over again. 9. Do you think the biopsy was a valuable part of your decision-making regarding treatment options? After the biopsy, I was less anxious about having a complete nephrectomy. It validated my earlier decision to remove the entire kidney. During the biopsy procedure, the physicians in the room discussed whether the samples they took were quality samples. They looked at the samples and commented that the samples dropped to the bottom of the specimen container. I asked them about it. The physician told me that samples that drop let them know the samples were good samples. They sampled a piece of the tumor, rather than fatty tissue that would float. That was a confidence builder for me as well. In retrospect, I didn't need to have a biopsy. Based on the CT scan, the radiologist and surgeon correctly diagnosed a cancerous tumor in my kidney. They couldn't definitively say it was a cancerous tumor based on the CT alone. The medical team was about 85% confident in their diagnosis. They felt the cancer was contained in the kidney and was likely clear cell renal cell carcinoma, stage 1 to 2. So the CT scan alone was all I needed for the diagnosis. That's the benefit of hindsight. It does bring up a good argument. Why put yourself through needless pain and expense, not to mention risk of complications, minimal as they are? That's an individual choice. I chose to get more information to confirm the cancer diagnosis prior to surgery. A second opinion, if you will. Other patients would make the opposite call. I respect that. Neither is right or wrong. It's a personal decision that you need to make after weighing the pros and cons. The pathologist who diagnosed my kidney biopsy determined it was clear cell renal cell carcinoma, grade 1 to 2. Again, that was not a definitive diagnosis, as there is a 15 to 20% chance a kidney biopsy will be a false positive or false negative. The biopsy on its own is not an exact science either. That's one argument for not having the biopsy. As it turned out, neither the CT scan nor the biopsy correctly reflected the grade of the tumor. The biopsy correctly showed the tumor was clear cell renal cell carcinoma. The final diagnosis by the pathologist, after my kidney was removed, showed the tumor had started to invade the renal vein in the kidney, something the CT scan did not reveal, upgrading the stage from 2 to 3. The final pathology also showed the grade to be higher than previously thought based on the CT scan and biopsy. The final grade was 3, not grade 2 based on the initial diagnosis from the CT scan and biopsy. This underscores the fact that medicine is not an exact science. CT scans and biopsies are not the final definitive diagnosis for kidney cancer tumors. Not until the pathologist is holding the kidney specimen in their hand, cuts it open, and subjects the tissue to rigorous pathology tests can there be 100% confidence in the diagnosis. Even the final pathology diagnosis is subject to human error. As a side note, when I read my final pathology report after the radical nephrectomy, I was pleased to see that the anatomic pathologist who handled my case was my friend, Dr. John Cheville. Dr. Cheville is an internationally respected renal pathologist who I worked with at Mayo Clinic and with whom I have great respect for as a physician and person. I knew my diagnosis was accurate and my kidney had been in good hands. Thank you, John. Given all of this, I would do it all over again if presented with similar circumstances. I wanted as much information as possible before having my entire right kidney removed. Until imaging can achieve 99.9% certainty of diagnosis for kidney cancer, which someday it probably will, I think there is a strong argument for having a kidney biopsy prior to a nephrectomy, particularly the complete removal of one. I hope this episode provided you with some thought-provoking points in making the decision whether to have a biopsy for a mass detected by imaging in the kidney. As you can tell from my experience, I support having a biopsy for masses less than 7 centimeters when medically indicated. Consult with your physician, get a second opinion, do your research with trusted sources from the top medical centers for the diagnosis and treatment of kidney cancer, MD Anderson, Memorial Sloan Kettering, and Mayo Clinic, to name a few, as well as from trusted organizations such as the American Cancer Society and the Kidney Cancer Association. I'm Alec, sitting in for Jeff Callis from Kidney Couch. Thank you for listening. Join me next time around the couch.